So we're going to jump straight in on some of the questions that women within the Kickass women's community have shared before this presentation. And Ginny's just going to go through the answers to some of these things. So the first one is like, I'm on the estrogen gel, which has taken the edge off some of my more intense symptoms, but this person's still having crazy mood swings, night sweats, and brain fog. So, is it worth staying on it? Your kind of answer on that?
Yeah. So I guess the first thing I would ask was how long has this woman been using it? And also wanted to know, yeah, but I would normally ask a few more questions around her menopausal status in terms of is she perimenopausal or postmenopausal? Because perimenopausal, you'll still be having your own hormone fluctuations in the background. Postmenopausal, your own hormones, the ovarian function has dropped off, so you're not making many of your own hormones, and that can make a difference to how the symptoms can fluctuate. So I want to know from whether someone's perimenopausal or postmenopausal, and also I'd want to know what type of progesterone they're using with the estrogen gel, because progesterone is there to protect the lining of the womb against the estrogen. And so, if someone's had a hysterectomy, or they may not need any progesterone, or they may have a Mirena coil. But again, it's sort of important to know what progesterone they are using, and how they're using it, whether they're using it continuously or cyclically, because again, that can also make a difference to the symptoms that someone's experiencing.
So breaking that down then, are you saying that if someone's perimenopausal, it's more likely that actually some of those symptoms may be due to fluctuating hormones compared to someone who's postmenopausal?
Possibly, yes, that's one of the reasons why somebody may still be having some symptoms, and that's where you'd then delve into a bit more details around the symptoms. Like, are they noticing them all the time, or do they come and go, and then they have a couple of weeks where their symptoms really flare up, and then they actually feel okay again. And yes, that can be due to their own hormone fluctuations in the background, and then we'd look at sort of adjusting their HRT dosages to try and stabilize those fluctuations.
Mm.
But the other thing is also to ask, to establish is the person using the gel properly? The gel's very popular; it's a really good product, but it does require time taken to absorb when you put it on your skin. So if you're somebody who slaps it on in the morning, shoves it on your clothes and rushes off out the door, or puts it on and then rushes off to the gym or to do your exercise class, it perhaps hasn't had enough time to sort of absorb and you sort of sweat it out. So are they using it properly? Where are they applying it? Are they always, do they need to, alter the area on the body that they're applying it? And the other
So
thing with, oh,
sorry,
sorry,
just picking up on that. So where would you suggest, because I think it might be interesting for people listening to this, where would you suggest that it should be applied is the best place?
so the most common place women will apply it is on their inner thighs, so more of a larger surface area for it to absorb. You can apply it onto your upper arms. Sometimes people do experience some breast tenderness if they're using it on their arms. So usually that's their inner thighs. But there's again, it's very individual, and what works for one person doesn't
And
necessarily
it should
work.
always make sure it should dry on your skin before you rush off in order to know that it's actually absorbed.
Yeah, and that can take sort of 15 to 20 minutes.
Yeah.
And then that's when then you can put your clothes on and go off to work. But if you were then to put it on, it's dry, but then you go straight for a swim or go and get sweaty doing your exercise, then that's going to sort of affect the absorption
Correct.
as well. So
Right,
they say
right.
to do that, to put it on, either do swim or exercise several hours after putting it on, or obviously do your exercise beforehand and then put it on, because you can put it on in the morning or the evening. It doesn't matter. It's just what works for that individual woman. If someone's using big dosages, so you'd normally start someone on one pump of the gel. It's a measured dose, see how they get on, and adjust the dose. And the sort of maximum licensed dose is 4 pumps.
Mm.
again, that would need to be discussed with your doctor, because of the higher dosages, you might need a change in your progesterone to protect the lining of the womb. But again, if you're using bigger dosages, that's quite a large volume of gel to absorb in one go. So once you're on the sort of the bigger dosages, we do recommend splitting it sort of morning and evening. But if it's just the 2 pump someone's using, they may choose to do it
That's
all
interesting.
at one time.
Yeah. So generally, it kind of the answer to that would be it depends, and it depends whether you're perimenopause or postmenopausal. There's those two things depend on the type of progesterone you're on and whether you're applying it properly. So you'd need to kind of
Yeah.
discount
Well,
both
whether
things.
you're applying it properly, and then also, the other thing is with the estrogen products that we have through the skin, that's gel, that's patches, that's spray. So we've moved much more to using these what we call transdermal products, and the reason being is they absorb directly into the bloodstream, whereas tablet estradiol, so that's the body identical estrogen that we have in HRT. If you have it in a tablet form, it goes through the digestive tract, gets metabolized through the liver, and as a result of that, it can increase our risk of blood clots and stroke. So we've moved very much more to using these transdermal, so through the skin products, because of the lower risk profile with them. But the difficulty with that is that everybody again absorbs differently. Now, some people just don't absorb well from the gel, or they don't absorb well from the patches. So again, yes, looking at sort of why this person still reports they're having symptoms, it's like, yes, like you said, are they using it properly? Are they giving it time for it to absorb? But actually, is this the right product for them? Are they on the right dose? Do they need to increase it? Or
Mm.
are they actually just not someone who absorbs gel very well, and then they would need to change to one of the other products? So I'd certainly say, is it worth staying on it? I mean, of course, it's, you never want to stay on anything that's not actually doing anything at all. But before just thinking, oh, well, I'll give this up, it's not worked for me, and look at really trying to optimize it,
Yeah. Yeah.
first off.
Yeah, yeah. So go back really to your GP, because I think lots of women tend to think this is it, this is the dose, this is and it's just that's it, one size fits all. And obviously it's like we're all very different. And so yeah.
Yeah,
Okay.
absolutely. Yeah.
Okay. Is that the next one? Yeah. So the second one is constantly feeling the need to urinate, going to the toilet and before they left the bathroom feeling like the need to go again. Is that a normal symptom of perimenopause, menopause? And if it is, what can you do about it?
Yeah, so I mean, a couple of things there is, I mean, certainly urinary symptoms, bladder symptoms can present in the perimenopause and the menopause. We call these sort of symptoms urogenital symptoms. So that's related to the bladder, but also then related to sort of the vagina. So vaginal dryness, vaginal soreness, changes within the vagina. So the urogenital symptoms of the menopause are very well recognized, and it's to do with the fact that we've got estrogen receptors on our vaginal tissues and on our bladder. So those fluctuating hormones in the perimenopause and then the dropping off of hormones postmenopausally will affect the bladder and the vaginal tissues. So yes, unfortunately, the symptoms, bladder symptoms, or as I said, you call them the urogenital symptoms, are some of the other symptoms that present. So is it a normal symptom? That's a difficult one to say. I say it's not unusual. Is it normal? I mean, that certainly we'd want to do something about it. So it doesn't, it's not something that, as in normal, I have to accept that that's what's
Mm.
happening. And the things that we can do for that is, as we said, they've got the estrogen receptors on the bladder, on the vaginal mucosa. So using what we call topical estrogen. So that's different from the transdermal, which is through the skin, which helps for what we call systemic symptoms, all those body symptoms. We use topical estrogens for the vaginal symptoms and the bladder symptoms. So that's localized treatment. So that's in the form of pessaries, little tablets you put into the vagina, or cream, or there's a couple of other products of a vaginal ring or a gel, and they absorb locally onto the estrogen receptors on the bladder and the vaginal mucosa to improve those symptoms. And they're very safe to use, very minimal absorption around the body. But there's also the other thing to say is that it's also when the type of symptoms this person describing, that kind of constantly needing to go, but then sort of needing to go again after going. And that's also worth looking at. Is that actually related to things like either an overactive bladder, which is
Mm.
not necessarily a menopausal symptom, that can happen at any age. It's not necessarily hormone related. There's certain things that can irritate the bladder, to give it that sort of feeling, instead of the bladder sort of filling up and then, oh, it's full, I need to go, and then you empties. It's just always there, feeling like it's sort of full, because the sort of the bladder is kind of irritable.
Mm.
And but also then this, I've been to the toilet, feel I need to go again, looking at, is there some what called incomplete emptying? Is the bladder fully emptying when you go? Are you sort of, rushing off too quick, or is there something that's stopping the bladder from fully emptying? So something like a prolapse or something. So, again, there's lots of different kind of reasons behind the sort of, urinary symptoms, the bladder symptoms. And it's, again, sort of talking to your doctor to really sort of establish, and does it sound that it's related to
Yeah.
the estrogen changes or irritability, and that may be something to do with medication or lifestyle things that you're using or taking,
Mm.
or is there a structural thing like a
Right.
prolapse?
Yeah, and actually that's also picking up on this because I think not that many women realize that UTIs are also a
Yeah.
hormonal impact as well. So maybe you can just touch upon that because I know lots of women suffer often from UTIs and don't connect the two.
Yeah, no, absolutely, and that's to do with the sort of the dropping, well, the changing of estrogen and the dropping off of estrogen, which keeps our sort of vaginal mucosa healthy, and so the vaginal mucosa thins, it becomes more dry, more friable, more, and the means that the bacteria can
Mm.
get in up the urethra and into the bladder. So yes, that's often one of the symptoms. Yeah,
Okay.
and actually, we see that in general practice. I see that a lot in older ladies. It's the kind of the bane of elderly ladies' lives, these urinary tract infections, and actually they have really sort of debilitating knock-on effects. You get a urinary tract infection, confused, fall
Yeah.
over, frail, and the recovery is very hard. And actually, you see these urine samples coming in, and so, oh, they've another UTI, and it's like, well, actually, maybe they need some vaginal estrogens, because that's a really good way to keep the vagina, the bladder healthy and reduce that risk. And
Yeah,
said
yeah,
they're safe because you get very minimal absorption around the body,
yeah.
so they're
And so you
not
can,
associated with
there's
risk.
no problem taking vaginal estrogen topical and estrogen in general.
No, so yeah, I mean, a lot of women will need to, if they're on what we call systemic HRT, so estrogen go around the body for all those other symptoms that we know associated with the menopause. It doesn't necessarily target the receptors, the estrogen receptors on the bladder or the vagina very effectively. So a lot of women will need to use the both,
Mm.
and it's just really important because I think as doctors we often forget to ask about those symptoms. Patients are often embarrassed to sort of ask, or they think, oh, I'm on the HRT, it should be doing, but no, a lot of women will need to do both. And the converse of that is true, is that some women don't want to take systemic HRT, so but they or they can't take systemic HRT, but they could use the localized
Right.
treatment.
Yeah,
Not for everybody. If there's a contraindication to systemic HRT, it may be that the localized treatments are not a good idea either. But again, it's to discuss that. But
yeah. And also, just to touch on that, is there a point of taking that localized thing for sexual relations as well?
oh, absolutely, yeah. For the vaginal dryness and soreness. I mean, it's if it's uncomfortable with to have sex,
That's
then
what would
you're not
you
going
use
to.
that for as well? Yeah.
Yeah, because, yeah, to help keep the vaginal tissues healthy, and so that it's not painful, to keep the tissues in the clitoral tissues in good condition, so that arousal is maintained, but also libido. We know that libido for a lot of women can drop off perimenopausally, and that's linked to the again the dropping off of our sort of our estrogen levels, but also our testosterone, which I know we're going to cover
Oh,
in a
yeah.
bit. But it's also important that if you're looking to sort of use the other treatments to improve libido, well, then you've also really important to sort of talk about, is there any vaginal dryness, is there any soreness? Because if you improve libido, and that's the sort of the sex drive, the sort of the mental sex drive, there's no point in improving that if then sex is going to be really uncomfortable,
Painful.
because then you're not going to want to have it anyway.
Yeah, yeah, yeah. Okay, let's move on to the next one. Oh, and we are talking about the yes, the testosterone here. Went on HRT for a year, because I wanted to try testosterone for my libido, but didn't make any difference. So maybe let's just tackle that bit of this question first, actually, because I think that's really important. And maybe if you can also touch on the other potential boosts that you get with testosterone in terms of energy levels,
Yeah,
and maybe
sure.
also touch on whether there is impact also on maintaining muscle mass as well.
Yeah. Okay. So, yes, so libido is complex,
Mm.
and there's lots and lots of other factors that affect our libido, and it's not just hormones. I think one of the phrases that is used is it's heart, head, and hormones.
Yes.
So again, when we I wish it was just okay, replace the hormones and everything's better, but that's not life. So it's really exploring with women what is going on, what are the other factors that could be affecting libido. Is it relationship things? Is it life things? Is it other medical conditions, other medications, all those sort of things? So exploring that, and then the guidelines at the moment for using testosterone for what it's called hypersexual desire disorder, but low libido in the menopause. The guidelines at the moment say that women need to be sort of on adequate estrogen first, and the reason is because actually estrogen does play a role in libido as well.
Mm.
And then if the women's are on adequate estrogen, adequate HRT regime, but still experiencing low libido, and I said those other aspects have been explored, then we would use you can do a trial of testosterone. But it also is important that actually we check testosterone levels first, because we wouldn't want to replace testosterone in women if they've actually already got a reasonable testosterone level. The caveat of all of this is actually, the testosterone levels that what we measure at the moment, is not the whole part of the story. We're
Mm.
measuring the amount of testosterone circulating around the blood. There's other parts of the story in terms of testosterone, what's going on, how testosterone's been utilized up in the brain, how it's being utilized inside the cells. But at the moment, the best we've got is measuring a level. And as I said, we don't want to be replacing giving a woman testosterone if their levels are already high, because then they're more likely to experience side effects, and those they're side effects that nobody would particularly want in terms
Such as what? What would the side
hair
effects?
growth, where you don't want hair growth, hair loss where you don't want hair loss,
Yeah.
oily skin, spotty skin, perhaps changes to some mood, or then actually some very sort of more very high levels, deepening of the voice.
Right. Right.
But I haven't seen, we're very cautious how we use testosterone now. Back in the day, we had things like testosterone implants, which gave women very sort of high levels. So now with the
Wow. I didn't know
products that
that.
we
I didn't know they did
that
implants.
we use, we can be quite sort of cautious with it. But the other thing is even if a woman's not noticing sort of side effects from that point of view, for high testosterone can also affect things like our cholesterol, our blood clotting, and our liver. So
Mm.
it is really important, as I said, to have a baseline level, and then have monitoring when when a woman's on testosterone, to make sure that we're maintaining their levels within what's called the female physiological range.
Yeah. Yeah.
Um,
And how
and
accurate are those blood tests for? Because presumably your hormone levels must fluctuate all the time from day to day, week to week, particularly in perimenopause.
Well, yeah, different. So for testosterone, so yeah, certainly, measuring hormone levels perimenopausally, but when we're talking about hormone levels, things of estrogen,
Mm.
that's what's erratically fluctuating in the perimenopause and then drops off a cliff postmenopausally. Whereas testosterone actually is more of a steady decline. Testosterone is produced by our ovaries, which,
Mm.
really sort of often surprises us, because you always think that it's, testosterone, our ovaries are estrogen, but actually most of our testosterone is produced by our ovaries, also some from our adrenal glands and some of our other tissues, but it's more of a steady decline. Actually, it steadily declines from about our mid-30s onwards. And that's often why the symptoms from low testosterone are sort of more sort of creep in, as opposed to the perimenopause, where suddenly, these big, wide, erratic fluctuations of estrogen causes these dramatic symptoms. It's more of a steady sort of decline. So measuring testosterone levels, you don't have that same issue with estrogen, when to do it in the menstrual cycle. Is it fluctuating? It can just be done. It's ideally done in the morning because that's when we get our natural spike of testosterone.
Right.
Uh, and then
Yeah.
yeah,
And,
and
and
then
so and so would you for this particular woman who said that it made no difference, why would that be the case? Would the case be, oh, you need more testosterone, or what would
yeah,
the
well, I think lots of different reasons. I would, first of all, be want to make sure that she's on adequate estrogen.
Mm,
So because actually, if estrogen levels are low, if she's not absorbing whatever estrogen she's using, then that will be having an impact on libido. So yeah, check that she's what we call adequately estrogenized. Then from the point of view of looking at the testosterone, like you said, yeah, are they absorbing it? Have the levels improved? Yeah, how is she actually sort of using it? And then, if the levels have improved, she's adequately estrogenized, but still just doesn't think it's, doing anything. But again, that's going back to let's talk about, libido. Is it
what is it?
actually something
Yeah,
that's not
yeah,
hormonal? Is there other things going on in life, or with her, other, medical problems or medications that could be, because
yeah, yeah.
several medications can affect libido
Yeah.
as well.
And what are the other potential benefits of taking testosterone? Or is it something that is not prescribed if you go in there just saying, I want it for, I don't know, energy or
Yeah.
increased muscle? What's the
Yeah,
view
so
on
I
that?
mean, so at the moment, on the NHS, following the kind of the principles of the NICE guidelines, that's the National Institute of Clinical Excellence, and then the British Menopausal Society guidelines, which and at the moment, the evidence that we have for testosterone is around using it for libido, and we don't have enough evidence to say that it has um, and positive impact on things like cognitive function, energy levels, muscle strength. But that's not to say just because we don't have the evidence that it doesn't do it. Because I been using testosterone replacement in my treatment of women with their hormonal imbalances, hormonal issues for many years now, and a lot of women do find that it's really kind of game changing from the point of view of their cognitive function, or their energy levels, or getting themselves back on track with their exercise performance. So it's difficult, because if you're going and asking for it on the NHS, you can and the NHS doctors, we have to sort of operate under the guidelines that we are given. So it does put in a difficult position if someone's saying, I want it for those other reasons, or my libido is fine, but so because and also because it's not actually licensed in the UK for
Yes.
women.
Yes, I was
um,
going to touch on that. So, like
mm,
in the UK, if you get it from the National Health Service, it's one that's actually used for men, isn't it? And if you get it
yeah.
privately, you can get the one that's from us that was they use in Australia. Is that right, or is it?
Yeah, I mean, so yes, a couple of other products privately. So because there isn't a license product for women on the NHS at the moment, unfortunately. But and because it's not licensed, many GPs are not comfortable prescribing it, which I think is fair enough. I mean, I prescribe it on the NHS, but I'm a menopause specialist, and
Yeah.
but there's other things when I work as a GP that I get asked to prescribe for other conditions that aren't licensed, and if I'm not trained in that area, I'm not going to be comfortable
No,
doing it.
for sure, sure.
But more and more GPs are doing the training and are more comfortable doing it. But then yes, there isn't a product. But it means that you use these products that are made for men, but at a lower dose. I
Yeah.
mean, testosterone is testosterone. There's no such thing as male testosterone or female testosterone. The molecule is the same. It's body identical testosterone. We just need less than
Less
men.
of it,
So
right?
if you're then using a product that's made for men, whether it's one of the pumps or a little sachet, Testogel sachet, you titrate the dose down. You take less. So a man, like the little Testogel sachets, they're about this big. A man would use the whole one every single day. For women, you open it up, you take a little tiny pea-sized amount out, and you make the sachet last about sort of 8 to 10 days, and then obviously adjust the dose according to response and blood levels.
Mm.
So it is a little bit fiddly, but equally, then yes, you're right. Privately, there's this product that's made in Australia. It's called Androfem. It's made for women. It's the same testosterone. It does, the packaging things makes it more kind of women kind of
Female, female marketing, right? Marketing.
yeah,
Yeah,
but
interesting. So it's
again,
exactly the same. It's just that it's
yeah,
just
well, I mean, and
packaged
that
differently.
in itself can be, it comes with a syringe, and
Yeah.
then you syringe out, you know, zero point 0.5 mLs, which then makes you feel like you get, you know, and it does give you a bit more of an accurate dosing. But the thing is, with all these things with the dosing, actually, it's very individual. Again, that comes where the monitoring is needed, because everybody, what one dose works for one woman is different for the next, because you might absorb it differently.
Mm.
But on privately, so we can get a product that's like a pump pack of cream that's then got a specified dose in it. It's much less fiddly than either the syringe that's used with Androfem or the tester gel sort of sachets. But again, that's, you know, there's cost implication of
Yeah,
that.
yeah.
But,
But your anecdotal evidence on it is that some women that you treat are getting better cognitive function and sports performance with taking testosterone.
yeah, I do see a lot of women who do report that. They say it's quite game changing for them.
Mm.
But yeah, it
Yeah,
has to be done sort of safely,
okay.
and
Yeah,
we can't at the moment kind of use that as a reason to prescribe it, because actually we don't have that evidence other than, like
evidence.
I said,
Yeah,
we've
yeah.
just got the anecdotal. So,
But back down to the whole issue of like not enough evidence or research on
yeah, but
any
there
of
are lots
women's
of
health.
trials going on at the moment around
Yeah, so which is
testosterone.
good. Yeah, yeah. And so,
Yeah,
and then taking it on to this next question, because it was, and I think I've kind of slightly lumped them together. Um, so this woman didn't have any symptoms from HRT, so therefore she was saying, "Well, should I take it anyway?" And then another person, so it's kind of similar question,
yeah,
has never been on HRT. So how could this affect the age
yeah.
of your body really and your optimum function? Can you get by without HRT and having this, exactly the same kind of if you're living well, doing all the right stuff? Have the same protective impact as HRT.
Yeah. Okay. So yeah, I mean, HRT does have other health benefits other than, you know, helping with the menopausal symptoms and helping you feel better.
Yeah.
We know that if HRT is used within what's called the window of opportunity, so that's 10 years within 10 years after menopause or under the age of 60, it helps to reduce our risk of cardiovascular disease, so heart disease. We also know that HRT helps protect our bones, because once we've gone through the menopause and our estrogen drops, our bones start to thin and we're at risk of osteoporosis. So HRT helps to protect our bones. So there are other health benefits,
And
but there
that's
are,
10 years. Sorry to just pick up the protective window is 10 years from the moment you are menopausal and
yeah,
afterwards,
or under the age of 60.
or
Yeah.
under the age of
Yeah.
60.
And
And
it doesn't mean that after, once you've missed that window of opportunity, it doesn't mean that then HRT increases your cardiovascular risk. It just means that it doesn't have those benefits. So if you're discussing with somebody, perhaps, you know, an older person, that they sort of say, oh, look, you know, I've been sort of 12 years since my last menstrual period. And, you know, I don't know whether it's worth it for me. And you're then drawing up a kind of pros and cons kind of list for them. You know, you might have the pros, which was, yes, it'll help you feel better. Yes, it'll help the bones. You don't have the pros for the cardiovascular benefits.
mm,
But it's also important to know that, you know, yes, it's got those health benefits, but because HRT does have risk, it's not used for what's called primary prevention. So primary prevention is when you use medication to try and prevent disease. So HRT at the moment is not recommended to go on to prevent heart disease,
mm,
you know, because, you know, that there are, you know, that there is still risks of it. So it's for that individuals, yeah, weighing up the kind of the positives versus the negatives. And when I talk about the negatives, that's the breast cancer risk with
yeah,
HRT.
yeah,
Um,
yeah. That's interesting
and
though, because the way because of the Davina McCall and menopause, it has almost seems to me like gone the other way, where everybody is just us. One of my clients from many years ago, contacted me on Instagram the other day and said all her friends who are under 39, 40 are taking HRT. And it seems to have gone literally flipped the other way, that everybody's just taking it because they think that that's what they should be doing, even potentially when they haven't even got any symptoms at all.
Yeah, I know, and there needs to be a balance, doesn't it?
Yeah,
But don't get me wrong, it's actually it really is life changing for a lot of
yeah,
women, and a lot of women for years and years were denied it, and
yes, yeah, yes,
the benefits to how it helps you feel, and the other health benefits. But yes, we do need to, it's not for everyone, and not everyone can take it, and not everybody wants to take it, and so going back to, like you said, can you get the benefits from other sort of lifestyle factors? Yes, I mean it's tricky. I don't think haven't got a sort of direct comparison to sort of actually if done studies to say, look, if somebody's got this and that and the other, and they're
yes,
doing this amount of exercise, they've got this in their diet, and they're not smoking, they're not drinking alcohol, they're not drinking caffeine. Are they still getting those same benefits to the heart and the bones? I
impossible to
mean, it's
say. Yeah,
impossible, yeah, because there's so many other individual sort of factors in that. Genetics for one, but
yeah, yeah,
I think we can't underestimate, which I'm probably talking to the converted here with your group, but we can't underestimate the benefits of those lifestyle interventions. And
yeah,
that's the thing I'd say to women is that I'd love it if HRT could do it all for them. It would make my job so much easier. But HRT is just part of managing
yeah.
perimenopause and menopausal symptoms, and actually it needs to be done with those other lifestyle factors. But I'd also say if someone's really struggling with their hormones, mood symptoms, sleep disturbance, all of those things, actually, feeling better from their hormone point of view will then also help them feel
Want
more
to do more stuff. Yeah,
motivated and energetic and
yeah,
active.
yeah. So let's go on. So this one, migraines. I hear this quite a lot. Women suffering from migraines. How much of this could be down to hormone change?
Yeah, yeah. I mean, certainly, we've known for a long time that that many women suffer with sort of hormone-related migraines, what we call cyclical migraines. So, women prior to the menopause, will often notice their migraines are worse at different times in their menstrual cycles, and then, and that's to do with the migraines being triggered by the hormonal changes in the menstrual cycles, and then obviously perimenopausally, those hormonal changes are then that much more sort of
Mm.
extreme and more erratic. So that can flare them up. Or equally, I see some women who have never had migraines before, and then when they become perimenopausal, start to sort of suffer from them. I mean, those are ones you'd probably want to just also investigate, make sure there isn't anything else going on, because
Yeah,
it's unusual to suddenly start presenting at that sort of age. But no, they migraines can be very much affected by hormone fluctuations. So in terms of then, what can I do? That's where we talk about stabilizing those hormone fluctuations. So again, that's the role where HRT will come in. But again, the right sort of HRT to try and, if someone's perimenopausal, to suppress their ovarian activity, to stop their own fluctuations in the background and completely stabilize their hormone levels
yeah.
there.
Okay.
Um,
And then I suppose this yeah touches on a little bit what you just said. Postmenopause for 5 years without HRT. Would there be any point in going on it now? I suppose it's a little bit of a confusing question because we don't know whether it means would there be any point in going on it now
yeah.
because I've got symptoms or
Yeah, I mean, I think exactly. I
still
think if they've got symptoms, and well, the other reason if somebody's had known to have osteopenia or osteoporosis, so their bones are starting to thin, then there would be the benefits there. But yeah, if they haven't got any issues with their bone density and they've got no symptoms at all, you might argue that it's not worth it. But yeah, very much
yeah,
depends on that
yeah.
person.
And then this whole thing, I think there's this kind of this horror around HRT. If you're on HRT, the minute you come off it, that somehow you're going to turn into this like old hag or something, that everything's going to drop and you're going to be like injured instantly. What's
Yeah.
what's the truth around
What will happen?
come off
Yeah,
it?
well, I mean, I think we there's no sort of general consensus of when someone's coming off HRT whether to sort of wean down from it or just come off it. However, most of us menopause specialists would recommend somebody wean down slowly, because if you're, been putting, the hormones back into the body, and, for however many years, and your body's stopped making them, but you're giving the body identical hormones back into the body with the HRT, and then you suddenly stop them. Well, certainly, menopausal symptoms can come back because they're just they're there as a result of
Hmm.
no hormones and you're taking those hormones away. So weaning down more slowly can minimize that impact. And, I would also say to somebody is to, do that. I mean, unless they have to come off it for sort of other sort of medical reasons, if it's actually just more their choice, they've been on it for a certain amount of years and think, okay, well, actually, now the risks outweigh the benefits for me, I'll come off it. I'd also say, well, just making sure that you're doing that when, you other things in life perhaps aren't so stressful, and whether that's possible, because I know life generally is pretty stressful, but you wouldn't want to do that when you've got lots of other family things going on or work stresses, because we do know how much of stress does impact our hormones and
Yeah,
how we feel. So trying to pick the right sort of time to do it, and also plan it, like I said, plan it around that you've got other sort of strategies in place if some of the symptoms are coming back, in terms of make sure you've got some ways to relieve the stress or to improve sleep. But
yeah,
yeah.
yeah. Okay. Um, and joints, big ones. So I've lumped this joints and tendons and ligaments. I hear this a lot from women about, their bodies just aching so much, and tendons and ligaments as well,
Yeah.
So can HRT help this? Like, what's going on?
Yeah, I mean, certainly. And so, I mean, we've got hormone receptors, estrogen receptors on every cell of our body. And that's why when we go through these hormonal changes, pretty much every system of our body can be affected in some way or another. And certainly joint pains, muscle aches. I see women presenting with a lot perimenopausally. And before we sort of recognize that this was one of the key symptoms that can happen, when we were being referred to rheumatologists or
Mm.
musculoskeletal teams to be investigated for inflammatory arthritises and osteoarthritises and things like that. But we do know that the estrogen has really important sort of impact on our connective tissues. So our tendons, our ligaments, has also got a role in our sort of cartilage. So that's the sort of the pad between the joints, which sort of stop the sort of the bones kind of rubbing together, and that's the one that then gets sort of thinner as with osteoarthritis. So we know that estrogen can affect all of those tissues. So certainly going on HRT, it does, if somebody's joint pains, muscle aches are related to their because obviously there can be other reasons, but if it is related to their hormone changes, HRT does help. Yes.
Does help, yeah, yeah. Um, and then connective tissue again, can it improve our skin elasticity? Because I know there are lots of people also attracted. I think I heard or read somewhere, which I thought was a bit of a terrible thing to put out. Like one of the menopause specialists had said something like, I walked into my clinic and you could tell exactly who was on menopause because they look younger. And I was like, I don't think that's quite the right thing you should be putting out there. But actually, what's the truth?
Yeah, I mean, well, again, estrogen does, does help with our, well, as I said, we've got, our the quality of our connective tissues and our elasticity, but, it doesn't, there's so many other factors with that. So I don't, and I don't see women who, start taking HRT and suddenly, oh my goodness, I'm,
Up a decade.
5 years, 10 years younger. Look at their skin sort of improved to back to what it was like when they were growing up. But it because there's so many other factors with
Yeah,
the skin, isn't
it's
there, in terms of
impossible. Yeah,
sun exposure, of whether we've been smokers or alcohol or genetics. But
yeah,
but
yeah,
yeah,
yeah, yeah. And actually, one other question, which I don't think is on this note, the merino coil, because I hear this a lot as well. Lots of women having no idea whether they are perimenopausal or menopausal because they're, well, menopausal they'll know. But, well, no, actually they don't because they're on the merino coil. So they have no cycle. And so many women are on the merino coil. Is there a benefit of coming off the merino coil so you have a bit more knowledge of what's going on with your body? Because obviously you now, if you're on the merino coil, that's your progesterone, isn't it? And then you're
yeah.
getting estrogen.
Yeah, so no, I mean, the Mirena coil for a lot of women will stop their periods. And so, they don't have that kind of changes to the menstrual cycles as a guide to, oh, I'm starting to go through the menopause, or I'm out the other side. But it doesn't, the progestogen in the Mirena coil acts locally in the womb. It thins the lining of the womb. So that's how it works for contraception. That's how it works for period control. And then, yes, it can be used as the progestogen part of HRT to protect the womb against the estrogen. So I wouldn't say to someone, oh, well, take it out and see what happens to your periods, because, if you're using it for contraception or period control, there's no point putting yourself through that, because, as I said, it can stop periods for a lot of women, but it won't impact those what we call the systemic symptoms. So in terms of the hot flushes, the sweats, the mood changes, cognitive symptoms, all those other perimenopausal symptoms will still happen. Well, if they're going to happen, whether someone's got the Mirena coil or not. I think it's just more that if you're then having those symptoms plus some changes to your periods, almost it validates it for you. Otherwise, you get those symptoms, you're thinking, oh, is it that I'm stressed? Is it I'm busy at work, or I've not slept well? And it takes longer to kind of realize that's what's sort of going on. But I think if you're over the age of 45, you've got a Mirena coil and starting to have those other symptoms, it's very likely that is the hormonal sort of changes of happening there. And as I said, the Mirena coil is three roles in one, because then if you then choose to then take HRT with estrogen, you've got the progestogen already in that Mirena coil to protect the womb. So I wouldn't.
Brilliant. If you've got a bit more time, Ginny, I'm just going to open it to any other questions or anything that's arisen for anybody on that topic. So if anybody wants to ask, like if you don't want to come on, you can ask in the chat box. So let me know if you've got any questions. You might actually need to come on, because I don't know where my chat box has got. Oh, hang on, there you go. I've got it. Got my chat box. So you can ask, or if you think everything's answered, then and you're really happy, put one in the chat box so we know that you think is fine. If you've got something you want to ask, either come on. Is the Mirena coil good for migraines? Can they help?
So yeah, so is it good for it? So the Mirena coil, for some women, it stops them. The progestogen in it will stop ovulation, but not for all women. So if it's stopping ovulation, it can stabilize the hormones, but it's more to do with the estrogen. But we actually, in terms of when we said sort of the right HRT for migraine sufferers, one of the kind of the best ways of doing that is with a Mirena coil and estrogen patches, which gives the most stable state of hormone, suppresses our own hormone fluctuations, give the most stable state of hormones. So yes, it can be used, but with estrogen.
Yeah. And then somebody had a question about, can taking HRT help with thinning hair?
So looking at kind of, there's lots of different reasons for thinning hair. It's not all just hormonal. So looking at sort of the type of where the hair is being thinned, is it what we call female pattern baldness, male pattern baldness, alopecia? So looking at kind of, where the hair is thinning, why it's thinning, the scalp quality. There's other factors around hair loss, hair thinning. Stress has a massive impact on our hair growth. Also looking at some vitamin deficiencies. So, usually if you went to your doctor and talked about some hair thinning, they would look at things like your ferritin level, zinc levels, thyroid function. But yeah, certainly sort of the changes in hormones can affect that, and it can be the dropping off of estrogen, but it also can be that if estrogen's dropping, testosterone is sort of dominating, and therefore giving that sort of what we call the male pattern sort of border sort of thinning at the front, because it may not be that testosterone is necessarily raised, but if it's not being balanced out by enough estrogen, it can dominate.
Yeah. So definitely going to your GP really to figure out which of those things it is. Yeah. The Women's Hormone Clinic is offering 20% off to new patient consultations using the code Kickass20.